We are going live in. We are going live in 5, 4, 3. We are live now.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about the pediatric elbow injuries, neglected pediatric elbow injuries. So over to you, sir.
Okay, thank you, Janki, and welcome everybody to today's webinar. I'm going to discuss neglected pediatric elbow fractures and injuries. And this is an area which is very challenging. And unfortunately, we do get to see a lot of this, and the decision making can be quite difficult. So unfortunately, neglected fractures are still a reality in our country. There could be many reasons for this. There could be delay in seeking treatment on the part of the patient. There could be a failure of diagnosis, and I'll come to that soon. Or they could come to the doctor or sometimes bone setters. The diagnosis of a fracture is made, but the treatment is not appropriate to what the injury is. So these can all be reasons for these patients presenting with problems or presenting late. And of course, like I mentioned, even proper treatment or correct treatment may sometimes have complications, and that is a challenge in itself. Okay, so the common elbow injuries, which are the most common injuries, are the supracondylar fracture, the lateral condyle fracture, and the Monteggia fracture dislocation. These are probably the three commonest fractures, but you also have other injuries. You have the medial epicondyle fractures, the elbow dislocations and fracture dislocations, and we're going to be showing some of those, and the so-called trash lesions, which was written up by James Kasser, which is what it stands for is the radiological appearance seems harmless. So what it means is that in these injuries, if you look at the x-rays, you do not really see anything significant, but the injury may be more sinister or more problematic than you think by just looking at the x-rays. And therefore, the clinical assessment becomes important. You need to look at the amount of swelling, if there's any bruising, any deformity, etc. Because in some of these children, the injuries could be osteochondral or mainly chondral, and you may not be able to see them on x-rays, and you may need to do appropriate investigations to find this. So there are various reasons of failures of diagnosis, and one could be poor quality x-rays. Sometimes the patient already has a slab put on, and then you don't bother taking it out before you do x-rays. And the x-rays you get are very difficult to make out anything on. It could be a lack of knowledge. So if one looks at this x-ray, and if one is aware of the fact that you can have a medial epicondyle injury that could be trapped in the joint, then you will not miss the diagnosis. But if you're not aware of this, then the chances are you will miss this diagnosis and this patient will present late. You can also have subtle injuries. A classical example of this is the lateral condyle fracture sometimes, which is totally undisplaced. And if you look at the AP and lateral x-rays in this patient, even in retrospect, when you know that there's a fracture, it's difficult to make out the fracture line. So what you need to do for these is to do a internal oblique view, the song view, when you see these patients and you suspect it and you cannot see anything on the x-rays. Or today with ultrasound or MRI, you can diagnose it. The problem with MRI is it often needs sometimes anesthesia or sometimes sedation before you can do the MRI. So ultrasound, if you have a person who is able to read the ultrasound, you can definitely pick up fractures on ultrasound. Now this patient, a week later, the fracture line is clearly visible. And then this displaces further and this child would need surgery. Now the problems of management is one, once they present late, the surgery can be difficult. The presentations are very varied, and we're going to go through some of that today. The guidelines are very scarce, again, because there's not enough literature on it. We are not sure about what we should be doing with them. Some of the guidelines are often dated, like if you look at the papers on the lateral condyle fracture, before the, say maybe 15 years ago, most of the papers would say that after 3 weeks, you should not be doing anything. And the literature, as I mentioned, is not very spectacular on this. It's in fact fairly sparse and will not give you all the methods or the techniques that you can use to deal with these fractures. Now, I'll start with some difficult situations and some relatively easier situations. And this is a child with a supracondylar fracture who was treated initially in a cast. The cast was taken out at 3 weeks, and then he was started on physiotherapy. But even after 3 or 4 weeks of physiotherapy, he had almost no movement. And you can see that there's a gross displacement. The proximal part of the distal humerus, which is the proximal fragment, has come down a long way and is almost abutting on the ulna and the radius here. And this is maybe causing a bony block, but also with time, there's a lot of fibrous tissue that forms, which makes the movement difficult. Now, it's a difficult situation. Generally, for late supracondylar fractures, if they're present more than 10 or 12 days later, we would allow the fracture to heal and then deal with the deformity later. And usually the range of movement is not a problem. But in something like this, where the range of movement is a problem, you are not sure that if you just treat it expectantly, whether you're going to get back the movement. So this is the case we decided. Now, this child had no massage. So what you see here is callus and not heterotopic ossification. If it was heterotopic ossification, then surgery would become a little risky. But in this case, because it's callus, we went in through a dual approach, medial and lateral. We shortened the bone a bit. We took off all the callus. We reduced it into a good position, and we fixed it stably with 3K wires. It's kept in a cast for 3 weeks, after which he was mobilized. And this is him at 10 months post-op. You can see how nicely the fracture has gone on to heal. There's no deformity. And this is his clinical movement, not a full range of motion, but fairly good functional range of motion, which will also, I think, probably improve more with time. So I think some of these, you have to make a clear decision that this patient is not going to do well with conservative treatment, whether we can go ahead and do something, but it needs a fair amount of experience as well as skill to be dealing with these kind of fractures. And not anyone should be doing these this kind of surgery. Now, here's another thing which is often missed. This is often diagnosed as a dislocated elbow, but this is essentially a transphysial injury of the distal humerus. So it's akin to the supracondylar fracture. You can see the displacement is medial. The dislocation, if it happens, is usually posterolateral, and this is one of the giveaways. The other thing is that the lateral condyle, if you look at the AP and lateral views, is in line with what would be the capitulum. So the whole distal humerus epiphysis has shifted medially and posteriorly. This was mistaken for a dislocation. This is the focused X-ray on the elbow at that time. It was mistaken for a dislocation, treated in a cast. They tried to do a reduction, and obviously the patient ended up with a deformity. And this is in 2.5 years later when they presented to us. So you can see there's a varus deformity. Now, mild degrees of displacement in these fractures, unlike the supracondylar fractures, may remodel to a good position and you may not have to do something. But this has a significant varus and we will need to do a valgus osteotomy to correct the deformity. There's no rush to do it, but whenever the child, usually we tend to do it at the age of 5 or 6 years, okay, or a minimum of a year after the fracture. Now, the lateral condyle is the other group of fractures which I mentioned, which are fairly common, not as common as supracondylar fractures, but probably surgical intervention is just as frequent. This is a 17-year-old. She has a tardy ulnar palsy. So one of the problems with these, if they do not unite, tend to be a progressive valgus deformity and eventually very often end up with a tardy ulnar palsy. Now, in these patients, you need to look at what the problems are. And I will go through the list of problems that you need to look at and also look at what the patient wants. In this case, she's a young girl. She wanted the deformity corrected. And obviously, you need to do something for the tardial palsy. She had no instability, no pain. The elbow was quite stable. So we decided not to do anything to the fracture. We went in from the medial side. You can see the nerve is all in fibrous tissue with severe compression. So we release the nerve, we transpose it anteriorly in a trough on the muscles over the flexor mass. And then we did an osteotomy here. We used a plate to fix the osteotomy so that we got a good correction of the deformity. And this is her 14 months post-op. You can see how the deformity is corrected adequately. She's got a good range of flexion and extension, as well as full range of supination, pronation, and the deformity is adequately corrected. So she's quite happy with the result. So here the problem was deformity and tardial nerve palsy, and that's what we did it with. There was no instability or no movement at the fracture. It had gone on to a fibrous union, so we did not do anything to the fracture. So the issues that we need to look at in these patients are: one is the deformity, two is if there's any instability, three, pain. So often instability will also have pain or any and ulnar nerve neuropathy. Stiffness is rare, but we do have some patients, and especially if they've had a vigorous massage, etc., or physiotherapy, they end up with stiff elbows. So here's a different sort of situation. It's a 6-year-old girl, much younger girl, 1 year since the injury, and she's been having progressive valgus deformity, mild pain on activity. So if she tries to pick up something heavy, she has pain. She has a good range of motion, but the elbow is unstable on clinical examination. You can see how there's a valgus varus instability at the fracture. So here what you would deal with is to correct the deformity, and here you can correct the deformity by just correcting the opening out the fracture area and putting in a bone graft here. So here a large tricortical bone graft, you release the fracture area, clear out the fibrous tissue, put in your bone graft, and the bone graft itself, when you do the correction of the deformity, gives you adequate room to correct the deformity. So this is fixed with these screws. She's got a good stable fixation, initial position in a cast for maybe 2 or 3 weeks, and then start mobilization. And this is her 6 months post-op, and this is her 2 years post-op. Again, you can see the deformity is corrected. She's got a full range of motion, and the fracture is healed nicely. So here the problem was instability and deformity. And this can be corrected by fixing the fracture with a bone graft, or the other option would be to fix the fracture and do an osteotomy to correct the deformity. But in this case, because it was a mobile kind of deformity, we could correct it with just opening out the gap and putting a wedge of tricortical bone graft and fixing the fracture. Now, the problem sometimes is in these patients who present late, when they haven't yet quite united. And this is a classical sort of situation which many of you might deal with, where a patient presents at somewhere between 6 weeks to 6 months. The fracture is displaced but not rotated, okay? So if it's rotated, it's a different situation. If it's not rotated, it's a different situation. Here, we can go in, we can see the fracture. You can see that very often the gap is more than you think. You need to release all this fibrous tissue, get the fracture reduced adequately, check that the articular surface is reduced, maintain the muscle attachment to the lateral epicondyle or the lateral condyle, and then you fix it. In the older children, we would use screws. Today, we have thinner screws, so we don't always have to use K-wires. You can use a combination of wires and screws. So here we put in a K-wire in the articular area and 2 screws into the metaphysis. And again, make sure you've got a full range of motion on the table. And this is him in his follow-up doing quite well. Today, with some of these fractures, we would not try to reduce it. So there's enough in the literature about fixation in situ. So in a similar case, more recently, on a girl who presented 6 weeks after injury. All we did was fix the fracture in situ. So a couple of screws to fix the fracture. You can do an arthrogram at the same time to make sure that there's no major step off in the articular surface. And this is her 2 years post-op. You can see again how the fracture's gone on to unite and is in good position and no significant deformity. So I think in these fractures which present late, which are not united, if they are not rotated, you can choose between open reduction and internal fixation or fixation in situ. There has been one paper from Delhi from, I think, Maulana Azad, which has looked at a comparative study between open reduction and internal fixation and fixation in situ and found similar results, although the reoperation rates were a little higher in the fixation in situ group. Now, the real problematic area is this, where patients present more than 3 months old with a completely rotated fragment. And here, the you really need to look at the mobility of the fragment. And if it is still mobile, I think we should go ahead and fix it. Of course, you have to be very careful with the dissection because the articular surface is rotated. So you need to be careful not to damage the articular surface with your dissection. That's your incision. We tend to go through the lateral approach. Some people prefer the posterior approach, but we keep the muscle attachment to the lateral condyle and epicondyle intact. We need to gradually release the fragment. You often have to lengthen the attachment of the muscles, release it gradually so that this fragment can come back and fit into the area where it has come off from. So you need to get a good articular reduction, visualize it accurately, then fix it with, today again, as I mentioned, we use these small 2.4 millimeter screws to fix these rather than K-wires. And this is him at 14 months post-op. You can see he's got a very good result, not a full range of motion, but a very good result considering his injury. Now, medial epicondyle fractures are usually less problematic unless the fragment is grossly displaced or incarcerated in the joint, when of course you need to do open reduction. The sort of treatment in the group that is between 5 to 10 millimeters displaced is still a little controversial, but I think sometimes they will end up with late instability if you treat them without surgery. And here's a patient who came to us 4 months after a displaced medial epicondyle fracture. And he had significant valgus instability. And you can see that on the X-ray. Clinically also, he had this valgus instability and pain. So here we decided to go in. So again, you have to be careful of the ulnar nerve, which you can see right there. You need to release that. You need to get to the area of the fracture, get the fragment, carefully reduce it, keeping the attachment of the muscles there, especially the flexor mass, whatever's attached to it, you need to keep it intact. And then you fix it with a combination of threaded wires and K-wires is what we used in this case. This is an old case way back in 2005. And again, this patient did well. This is him 9 months post-op, doing quite well with a good range of motion and now, even if it goes into fibrous union or not, it doesn't matter as long as the stability is restored. And if you see that the physis in this area is still intact, so the opposite side, we still have a gap, and here we still have a gap. Now, the area that you have to be careful is the medial condyle fracture, okay? So the medial condyle fractures, if you see what looks like a medial epicondyle fracture in a child below 7 years or 6 years, be careful, because the medial condyle and epicondyle medial epicondyle has not appeared as yet, okay? So very often this could be a medial condyle fracture. So it's an intra-articular fracture with a much poorer prognosis and needs to be internally fixed with accurate open reduction, okay? Now, this is a fracture which is very often missed and ends up with problems. So this is a common it's not a common fracture, but it's common to have problems with this fracture if they're present to somewhere, because they're very often misdiagnosed. So here's a patient who presented to us 2 months after a medial condyle fracture. You can see here the fracture involves this whole area. You can hardly see the fragment, but there's some calcification here, and you have to go down, release the fracture. So there's a fragment there, and you need to release it, get it back into place, fix it. Unfortunately, we have only a 4-week follow-up on this patient. We don't have a longer follow-up, so we cannot tell you how well he did, but these are very prone for avascular necrosis and problems when you treat these fractures late. Now we come to the Monteggia lesions, and these are could be either fractures which have been missed, or sometimes you could have a plastic deformity of the ulna with dislocation of the radial head, which has not been diagnosed. You can have inadequate reduction of Monteggia fracture dislocation, or you may be able to reduce it, but it redislocates. So various problems can occur. But these fractures presenting late is not uncommon. You can see here there's a clear angulation in the ulna, and the radial head is dislocated anterior, so a typical type 1 Monteggia. And this patient presented 1 year after his injury. So at this stage, usually today with the angulation distraction osteotomies, we can get most of these reduced, okay? So here we are doing a step cut osteotomy. We are distracting it. You can use a laminar spreader to distract it. You angulate it, and then you put in a lag screw and then a protection plate over it. So this is how you have angulated and distracted the ulna, and you can see how the radial head has fallen back into place. And then this is the follow-up X-ray, and this is him at about 1.5 years post-op. You can see he's got a full range of flexion extension, and his pronation supination is also quite good. You can see he's got almost a full range of pronation and supination. Some of these patients will lose a bit of pronosupination, and this is something that you have to counsel them about. And the older it is, the more likely it is. And this is a patient which presented to us 4 years after injury. Now, I think after 3, it's a debatable situation whether you should go ahead and do this kind of surgery. But here we decided to do it because we've done it up to 6 years. But I think the older you do it, the more risky it becomes. You very often have to do an open reduction of the radial head. You need to release all the fibrous tissue that is there so that the head can come back into place. Then you do your angulation distraction osteotomy, which is a step cut osteotomy. That you can see how it's angulated and distracted, and the radial head is back in place. Now, if you're still worried about the stability of the radial head, you can do something like a Peltau's procedure using the triceps fascia. Very rarely do we put in K-wires. I think if we looked at our earlier cases, we did put in K-wires, transcapitular K-wires or K-wires into the ulna occasionally, but nowadays we are doing it almost very, very rarely, and not in the straightforward Monteggia fracture dislocations. Almost we haven't done that for some time. So there, this is the post-op X-ray, and again, this is in at 2 years post-op. You can see he's lost a bit of pronation, but otherwise flexion extension is quite good. Although the X-ray shows a deformity, there's no obvious deformity clinically. Okay, so again, he's doing quite well considering the late presentation after 4 years. Now, the type 3 Monteggia is an unusual fracture, and this is the one which very often you can have a posterior interosseous nerve palsy, and the posterior interosseous nerve may be entrapped as well. So there's a situation where the patient who came to us after some time, she had a closed reduction done, which looks reasonable. But again, if you look at the ulna, there's still a plastic deformity. And if you compare it to the normal side, you can see that the radial head is still a little sublux. So because she had a posterior interosseous nerve palsy, we decided to explore the nerve. You can see it's ensheathed in fibrous tissue. Sorry, it's ensheathed in fibrous tissue. We released it, and then we did an osteotomy of the ulna, and now the radial head is nicely sitting on the capitellum. And this is the follow-up of after the titanium elastic nail has been removed. She's got a full range of movement. The scar is a little hypertrophic, but there's no clinical problem associated with the scar except maybe the cosmetic part of it. Now we come to a group of unusual presentations of patients who came with difficult problems late. Okay, so here's a 6-year-old child where the diagnosis can also be a problem and the treatment can be a problem. So it's a 5-month-old injury, initially treated by a local bone setter. She has a minimal range of motion, so just a jog of movement, and that is what her X-rays look like. Now, you really need to be careful about assessing these and making a correct diagnosis. So you can see here that the radial head is along with the capitellum is along with the shaft and is sort of dislocated from the olecranon. And if you look more carefully at the trochlea, this is actually lying here, not quite on the at the level of the olecranon, slightly lateralized, but at the level of the olecranon. So here, being a 6-year-old child, we didn't want to do an osteotomy. We were thinking of what would be the best approach. You can see how the callus is formed here, and it's the fractures united. This is the trochlea part of it. This is the capitellar part of it. And here you can see the healing. So we decided to use from the adult the trap approach. So again, you can see how the triceps fascia has been raised along with the anconeus. That is the cartilaginous part of the olecranon. That's the ulnar nerve. Always the ulnar nerve is the first step. You need to release it. And then we release gradually all the soft tissue. And you can see how this is the trochlea part lying here. And here's the radial head, or the capitellum lying anteriorly and dislocated. So we get this all released. So here you can see that there's a callus here. We need to release this. We need to get this fragment down to this position where it's supposed to be reduced, fixed with K-wires, brought back into the joint. The triceps fascia is now repaired. Because this has been out of joint for a long time, we put a transcapitellar pin, a transolecranon pin into the joint just to hold things in place for about 3 weeks. Then we take out the wire, put him in a more flexed position in the cast for another 2 weeks before we start mobilization. This is her at 4 months post-op. This is her at 28 months post-op. And this is her at 5 years post-op. Again, much better than before. Not a full range of motion, but a functional range of motion. She's still not got complete extension, but flexion is almost complete. So quite a good result in a difficult situation. Here's another patient. This is a 12-year-old boy who presented to us 4 months after injury, which was treated in a cast. He's got a deformity and a limited range of motion. Now, if you look at this, again, you can see that the elbow is dislocated, the radial head is dislocated, and if you look at the fracture, it was a transolecranon fracture, which has malunited in lengthening, okay? So if you see this, you can see how the olecranon is lengthened and malunited. Okay, so here, what you have to plan in your correction is to also take off a wedge from here to get the olecranon back into shape, okay? So that's what we did. We did all the releases, an olecranon osteotomy, took off a wedge from the olecranon. So the olecranon was shaped more like it's meant to be. This is a transcapitellar wire for the radial head, which was dislocated. And the elbow was quite stable. So this is after the wire's been removed. He started mobilization. This is him at about 6 months, still quite stiff. But gradually, he's getting back his motion. And at 2 years, he's got almost a full range of motion. just the terminal extension left, and a very good range of motion and good function. Now, what about stiffness and heterotopic ossification? This was a child who had a fracture dislocation elbow, which was dealt with elsewhere. This was treated by closed reduction, which was, I think, the main dislocation was reduced, but there was still some angulation of the fracture. He was then given vigorous physiotherapy, and he came to us a year down the line with heterotopic ossification, which had completely blocked any movement and joined the distal humerus with the proximal ulna. So here we had to, again, we did CTs to assess the entire extent of the myositis or the heterotopic ossification. Here we went in through a medial approach. We took off the entire flexor ward with the nerve anteriorly, and then went right across the coronoid process of the ulna across from this side. Okay, so now you can see very clearly the entire heterotopic ossification mass from the ulna going on to the humerus. We excised this with the osteotome, being careful not to go into normal bone. So we take off a little less and then nibble out whatever remaining is there. And then we also need to do an arthrolysis, because by now the joint is quite stiff. You can see the nice cartilage in the joint. So you need to get into these areas, take out all the fibrous tissue, release it completely so that you've got a close to a full range of motion on the table. I think if you don't do that, the likeliness of you to be having a stiff elbow increases significantly. Again, that's the post-operative X-ray in the car. This is him at 6 months post-op. You can see he's got a fairly good range of motion. The elbow is reduced in joint. There's a slight varus deformity if you look at it, which was there from before, but he's got a good range of motion and no recurrence of the heterotopic ossification. And now we come to compartment syndromes, and this is a problem which unfortunately, again, we still see from time to time, not often, usually due to a tight cast, sometimes due to indigenous treatment. And what you don't want to have is situations like this, which may require even an amputation to correct. VIC is a problem that we do again see from time to time, where the compartment syndrome is not bad enough for them to need an amputation, but they end up with these ischemic contractures, and here you can release it. Now, this was the preoperative position, and you can see after all the releases, she'd got back a reasonable position correction of the VIC. Can have more difficult cases like this child who presented to us 5 days after the injury, and by the third day he gradually started losing movement and sensation in the fingers. So came to us at a time where the forearm was still quite tense. He still had some pain on extension of the fingers, but almost no active motion and almost complete loss of sensation. So here we counseled the patient and said, I think if we go in, we should be able to get some improvement. So we did a very massive release of all the compartments, all the nerves and compartments. This is the fracture area. So we went and did an open reduction through the anterior approach. All the dead muscle that was there, some of this yellow ischemic muscle had to be excised. We put in K-wires into the fracture and released everything. So you can see the nerves, the muscles, all the compartments have been reduced adequately all the way to the median nerve in the wrist. And it needed a split skin graft after a few days once things had settled down. And then he gradually recovered function. So you can see that he's getting back his motion, his flexion, etc. And also you can see how the VIC part is corrected, and he ends up with a reasonable function. It's not a normal function, but he's able to pick up objects. So he can pick up a coin even. He's able to make a fist, but he needs some help with his opposite hand to make a fist at this stage, but he can make a fist, and he can, as you can see, he can make a pinch grip with objects. So eventually he recovered a reasonable function, but obviously not a normal function of the hand. And one last case, this is a case we dealt with very recently. and probably one of the most challenging cases we faced. This was the original X-ray. This was treated in a cast with closed reduction, attempted closed reduction. That was the X-ray after the cast was removed and he was mobilized. You can see this position is not okay. And this is what the AP and lateral X-rays and that of the opposite side were sort of looked like. And so we got some oblique X-rays also. So it was, the humerus was so rotated that what was done as lateral was actually an oblique, and what was done as an oblique was more of a lateral X-ray, showing a clear dislocation here. Here's the fragment of the lateral epicondyle, which is separate. And this was a real challenge. So we went in, that was the CT scan, again, confirming the diagnosis. Again, only a jog of movement, really almost no movement in the elbow joint. So because of this problem, we thought we should do something. Those are the markings before surgery. You can see how the anatomy is grossly disturbed. You can see how kinked the ulnar nerve is. So you have to very carefully release the ulnar nerve first as the first stage of your operation. Here again, we decided on a trap approach, releasing, along with the anconius, we took off the entire triceps fascia off the ulna and the olecranon. Again, you can see this whole flap there. This is the olecranon part, the cartilaginous part. This is the proximal ulna. And now we have to go into the joint gradually. You can see how this is the radial head. This is the area of the olecranon. There's a lot of fibrous tissue here because the joint was dislocated. So we have to release that very carefully, not to damage the articular cartilage. There was some deformity of the articular cartilage there, but bit by bit, you can see once we've released all this, we got a reasonable. So this is the fragment of the lateral condyle has now been mobilized. It's lying under my thumb with the extensor muscles attached to it. This is the trochlear part, and this is the gap. We need to kind of take off a bit of bone to make the space for this fragment to fit in there. Once we do that, we get it back into position. We reduce the joint. We put in these provisional K-wires to fix our fragment there. You can see how the 3 K-wires, one going across the joint and 2 into the one here is going across the joint. These 2 are going into the metaphysis. And then we also had to put in a transolecranon pin to hold the joint in position because it was still unstable. So then we replaced these K-wires with screws and fixed it, repaired the triceps fascia. These are the Shyam images. You can see how we've been able to reconstruct the anatomy quite well. This is still, we still haven't taken out the transolecranon wire, which is due to come out, I think, next week. And then we're going to start trying to mobilize the elbow. So it's a bit early and a very difficult and challenging case that we tried to salvage with late open reduction and internal fixation. So I think in conclusion, these elbow injuries in children are a challenging problem to deal with. And when they're present late, they're even more difficult. In fact, Mercer Rang was one of the early pediatric orthopedic surgeons from Canada, had said that he pities the young orthopedic resident whose first case is a child with an elbow fracture, because their diagnosis, the treatment can all be difficult. And of course, when they present late, the problems are even more difficult. The decision making has to consider the disability as well as the benefits and risks of surgical treatment. So when you're operating on them late, obviously there are certain risks which are not as much there when you're operating early. You need to have a very good idea of the anatomy, the various physial elements of the distal humerus, which you appear at different times. You have to be aware of the anatomy, the chronology of the appearances of the various physial elements, which you should be aware of to make a diagnosis, and then make a sort of counsel decision of the surgical treatment if you're planning to undertake it. And we really need to know long-term results. Some of these we have been able to follow up for a reasonable time. But some of the others, with the smaller children, really need to be followed up to skeletal maturity before we can really say that these methods are justified in these late cases. So thank you very much. I'll stop sharing, and if there are any questions, I'll be happy to take them.
Thank you very much, sir. So we are waiting for the questions. As before that, sir, one thing which I want to ask in management of lateral condyle non-union, sometimes you use direct fixation, sometimes you use bone graft. So what are the criteria to decide about that?
So I think there are two ways. If you're doing a open reduction and fixation into so try to get an articular reconstruction, then very often by the time you've got everything released and got things into place, you actually have to make place for the fragment. Okay, so I find that you very rarely need bone graft in those situations. If you're doing a correction of deformity at the non-union without doing an open reduction of the fragment, then you have to put in bone graft. Okay. Now the other way of avoiding bone graft would be to do an osteotomy and correct the deformity and then fix the fracture for stability. So you need to look at what problems the child has and then plan your treatment accordingly to deal with the problems that the child has. So if instability, you need to fix it. If it's deformity, you need to correct it. If there is non-union, you need to deal with that to get a union of and if there's ulnar nerve palsy, you need to deal with that.
So you have mentioned in your lecture, sir, that when you're doing after 3 years for Monteggia dislocation or radial head dislocation, it's that is something risky. So what are the risks we can consider?
So that 2 or 3 basic risks. One is posterior atrocious nerve palsy. Okay, because when you're releasing the radial head and getting it back into place, that is an area of where it could be damaged. Second thing is to get a stable reduction may be more and more difficult because the radial head starts getting deformed after some time. Okay, so it may not be a congruent reduction even if you get it. Interestingly, we did one which was 6 years old, and interestingly, the radial head, which was quite deformed, actually remodeled to look reasonably good at the end of 2 years after the reduction. But I think if it's reaching an older age, then you have to debate between whether excising it is a simpler solution than reducing it and trying to keep it in the correct position. So
one thing, sir, that in what term it is difficult to manage a elbow injury in pediatric when we compare it with the adult counterpart?
So, I mean, as I mentioned, there are basically 3 problems. One is the diagnosis.
Yes, sir.
Second is decision making, and third is the surgery. Okay, because you are dealing with areas of physis, you're dealing with areas of, so like in the supracondylar fracture, you're looking at nerves and vessels. So even when you're doing closed pinning, you can damage the ulnar nerve. If you're putting an ulnar wire, if you're putting a Doggins spin, which is to try and avoid the pin through the ulnar side distally, but you want to fix the medial side. So there's been a recommendation of putting a pin from the proximal fragment into the distal fragment from the lateral side. But there you risk the radial nerve injury. Okay, so the vessels can be injured in the thing. You have something called the pink pulseless hand where you cannot feel a pulse, but the perfusion seems to be okay. So you need to decide what to do in those situations. Most of those, if you look at the literature, can be managed without vascular surgery, but the ones which are white and pulseless definitely would need a vascular reconstruction. Okay.
So,
especially if
number-
they remain like that after reduction. Some of these, once you reduce the fracture, will improve. But if they still remain, then you need to explore the artery.
So, one thing, sir, like in yesterday in late evening in our OPD, actually, other consultant was not there. So one child came, that is 5-year-old, and with the elbow pronated with supination was difficult, although there was no pain. And the mother told that about 4 or 5 days back, there was injury in the elbow, although he has one X-ray of that limb only. So there was
That's
no
a classical pulled elbow in a child. Yeah.
Yes, sir. So, but the only thing, sir, like because there was no radiological diagnosis.
So you don't see
So-
anything on the X-rays in that, no?
And sir, that after 5 days it was difficult because I did that maneuver. It was not coming back with that one. So in those cases, sir, how to proceed?
You have to get it back. Get the so first thing is to get a diagnosis. Okay. So
Yes,
just X-rays are not enough.
yeah,
Okay,
ultrasound. I told, but the mother was not ready yesterday. Told she will come tomorrow.
So I think if you have if you are not able to get the maneuver and get back so very often they just pop into place and then they
Yes,
are able to move this. So
Yeah,
I mean, even up to 4-5 days, that should be possible normally. But if that's not happening, you need to make sure that there's no other injury. Okay. So you can
Yes,
have
sir.
osteochondral fractures, you can have radial head fractures. Okay. Which radial neck fractures, again, you can have medial condylar fractures, which will not show up on the X-ray sometimes.
Yes.
So clinically, was it tender anywhere?
No, it
No
was not
tenderness
tender.
anywhere.
No, sir. Even with the maneuver also,
No,
he was
so
quite up.
if it's a pulled elbow, they will not let you touch the elbow easily.
Yes, sir, but it was 5-day-old, so I was thinking maybe after 5 days the pain was not there.
So it's difficult to say something like that without looking at the X-rays and the patient.
Yes, sir, but the next approach should be, sir, ultrasound or anything else we need to do to
Yeah,
confirm
so
our
if you can
diagnosis.
get a good ultrasound, that is helpful. Otherwise, an MRI.
Okay, sir. Yes, sir. So actually, there was no question in the chat box. I'll just check. Yeah.
How to decide about ballonated pediatric fracture will
Okay.
get corrected by remodeling, and when is intervention required? So there's a question there in the chat box.
Yes, sir. I got that one, sir. Avinash has asked.
Okay,
about
so
that.
I think if you're talking about supracondylar fractures, they do not remodel generally. Okay,
Yes,
so
sir.
don't expect remodeling in a supracondylar fracture. So if the deformity is significant, normally you would wait for some time to make sure it's not a progressive deformity, because some of these patients may have a AVN of the trochlea, and there the deformity will progress. Okay, and usually we would wait at least 9 months or a year before doing the osteotomy. Okay, or in a small child, wait till they are 5 or 6 before doing the osteotomy.
Yes.
Now, which elbow injury will remodel? I think the only one that there may be some remodeling, that do not complete remodeling, is the transphysial injury in a very small child. Okay, now posterior angulation. So if you have an elbow injury with just posterior angulation, but no varus valgus, that can remodel. Okay, but not the varus valgus angulation. Okay.
Okay.
In fact, some of these you need to watch out for progression of deformity. Okay, because if you have now lateral epicondyle, again, the deformity occurs after some time. So they get a progressive valgus deformity. Okay. So I think you may watch out. So most elbow injuries, if there's a deformity, will not remodel, because if you look at the growth, unlike the lower limb where the growth takes place in the distal femur and the proximal tibia, here the growth takes place in the proximal humerus and the distal radius. Okay, the majority of the growth. So there's not so much growth in the elbow region to give you the growth that you need to get remodeling.
Yes. So one thing what you have taught.
So distal radius fractures almost 60-70 degrees will remodel. Huh? So proximal humerus fractures, very gross deformities will remodel, but not so much in the distal humerus or proximal ulna.
Yes. So one thing I think you have taught us in masterclass pediatric ortho that the deformity which is for the forearm fracture it was told sir, that which is in the range of motion like the flexion and extension that make it remodel but not otherwise. I think that holds good for this one also.
Yeah, so like that's what I said. So extension deformity or flexion deformity to some extent may remodel, but not varus valgus.
So there is one question by Subhanshu. He asked about distal humerus physeal compressive injury, whether this lead to neglected elbow injury. So how to assess that type of injuries? Physeal compressive injury.
By physeal compressive injury?
Probably he was asking about type 5 Salter Harris.
So what do you mean by that?
Subhanshu? You unmute yourself. Yeah.
Sir, if there is a physeal injury, patient having the fall and having the pain in the elbow, and X-ray looks normal because it's a physeal injury. After some time, patient having the not the growth, not the proper growth of the bone and.
So let's put it this way. All physeal compression injuries need to be, they get diagnosed in follow-up, not directly at the time of injury. Okay. Physeal compression injuries are rare in the distal humerus. Okay. You don't very often get, it's more common in areas like the ankle or knee to some extent than in the sort of distal humerus or proximal ulna. Yeah.
Yes, sir.
Yes, sir.
So you can get avian of the trochlea in a supracondylar fracture. That is something that is known about. In medial condyle fractures, avian is not uncommon. But compression injuries, so what the only thing that you need to watch out in undisplaced supracondylar fractures or relatively undisplaced supracondylar fractures are the varus impacted fractures. Okay, so the X-ray will look innocuous. There'll be a bit of varus impaction, and those will heal in varus. Okay, you don't notice it on the X-rays, but they'll heal in varus, not because of a growth injury, but because there's a deformity at the metaphysis which you have not been able to diagnose or correct in the initial. So very often these need to be corrected and pinned with K-wires so that they do not end up with a varus deformity. So we've got one or two, I think, in our series of patients who had this varus impacted fractures, which look like type 1 fractures, but there is impaction on the medial side, which leads to a deformity. Okay?
Okay, sir. Thank you, sir.
And so what you have shown that medial epicondyle physeal injury, which looks like posteromedial dislocation in child. That is also physeal injuries.
Yeah, so that is a transphyseal. So the entire distal humerus from the physis moves medially and posteriorly. Okay. So it very often gets, if you look at the X-ray, it looks like a dislocation because you can't see the physis.
Yes.
Okay, so what you need to follow is the line of the radial head and see whether it is lining up with, if the capitellum is there. If the capitellum is not there, then it becomes even more difficult. Okay.
Yes.
So,
Yes.
but you should be able to tell by the direction of the deformity. A elbow dislocation will almost always be posterolateral. If it's posteromedial, then it's more likely to be a transphyseal separation of the distal humerus. Okay.
So just a few words about what we are giving indomethacin or physiotherapy postoperatively in adult. Any counterpart of that in
This is not an adult webinar. Okay. Pediatric elbow injuries, again, you can give them indomethacin, but you would do it only in the ones where your dealing with heterotopic ossification. Okay,
Yes.
so the other option for that is radiotherapy, which is not possible in pediatric age group. Okay, so when the child is still growing, then usually the radiotherapist will not give radiotherapy because it may affect growth.
Yes, sir.
Okay.
Yes, sir. Just one last question, sir. Like what we like pulled elbow and transepiphyseal injury, these can be put in under trash, sir, according to the definition. Like radiological appearance is harmless, seen harmless. Is that under pulled elbow and all?
So read the article, you'll know what all are there.
Yes, sir. Okay, sir.
So there are 2 articles on that, trash elbows. So all these injuries like lateral condyle fractures, medial condyle fractures, transphyseal injuries, all of these come under. So basically, if the X-ray, basically what trash means is the X-ray looks harmless or the radiological appearance seems harmless. That's what trash stands for.
Like
But
what
injury is more significant, okay, which can lead to problems of either long-term sequelae or stiffness or whatever, deformity, etc. So I think, sorry?
So what we call like Sivora in a spinal cord is stress in elbow. Is that okay, sir? Like a spinal cord injury without radiological appearance.
Similar, okay?
Similar things.
But there's a cord injury. Here the injury is actually in the bone maybe, but you're not seeing it.
Okay, sir.
Okay, because of the cartilage. So there, the injury is not in the spine, but in the cord, okay?
Yes.
So they get neurological problems without any
Yes.
displacement in the spine.
Yes. Okay, sir. So,
Okay, I think we
Yes,
should
sir.
call it a day. It's almost
Yeah.
8
Yes, sir.
o'clock.
Yes.
Okay, thank you
Yes.
very much.
Thank you very
Thank you,
much, sir.
sir.
It was very informative. So,
Yeah, this
Thank
is
you,
a not, this is kind of a difficult topic.
yes, sir.
I'm not sure if it's only designed for postgraduate students or more kind of.
Yes, sir. But it was very helpful.
It's important to know about.
It will be very helpful during clinical examinations, sir, because they usually show the X-ray and ask the diagnosis,
Sure.
and even for the OSCE. Thank you very much, sir. Thank you, sir.
Okay, bye, everybody.
Thank you, sir.